Well, welcome everybody to Optometric Education Consultants National Webinar Series, Sunday night edition. Our speaker tonight is Dr. David Nelson. He's a graduate of the Indiana University School of Optometry, and most impressively, he served as the 80th president of the American Optometric Association, following his 8 years of service on the Board of Trustees. He has served as the AOA's representative to the World Council of Optometry meetings in South Africa and Finland, and attending meetings in Japan for the AOA's Ophthalmic Council. He is board certified and represents approximately 15% of practicing optometrists who have undergone this additional certification. He has served as vice president for the professional relations with Optos PLC, Arctic DX, and currently IMART. And he has done a number of educational lectures across the U.S. So with it, it is really our great privilege and an opportunity to have Dr. Dave Nelson speak to us, and I am very much looking forward to it. So with that, David, please take it away.
Thanks very much, Joe, and Greg as well. Appreciate you having me here, and thank you for all attending as well to talk about a little bit about our journey through eye care and taking care of people. And I found it to be very, very interesting over the years, and it continues to be with technology and devices to be even more interesting as time goes on. I've been asked to add relevant disclosures have been mitigated. I'm currently consulting with Luminous B with intense pulse light and other devices. I've had past consulting relationships, and I independently worked on this preparation, and the content has been presented without commercial bias. So my journey in optometry, several decades in, 2 decades in association optometry. I was past president of 2 national associations and 1 state association. And my major activity in optometry association was membership and advanced scope of practice in optometry, getting optometrists the statutory ability to treat eye disease with therapeutical pharmaceutical agents. And Wisconsin, I was on the committee that wound up being successful in passing therapeutic legislation as the 25th state in 1991. And it's been pretty much the foundation of my entire life. But when I got involved in Optos for about 10, 15 years, my experience changed greatly. And I became much more involved in trying to prevent the disease that optometrists are now trying to treat, because it's so much more difficult to actually treat people that have developed diseases than it is to try and hone habits that make a difference in keeping them from having these kinds of problems. So I got back from my holiday vacation. I was in Mexico and had a really nice time. And on January 6th, I came into the practice and I had a white male, 74-year-old routine exam. And I was given the chart after the technician worked up the patient's file, and wife was there. And the chief complaint had been put in by the technician. It says, blurred vision involving right and left eye, blurred vision, computer distance near and notable when driving, with floaters, wearing glasses and read. I mean, what a kind of junk is this in our in our chief complaint? He said blurred vision has been present for years, and aren't EHRs so wonderful? So I asked him, cut to the chase, why are you here? And he says, well, I have to close my right eye when I read at night. And so I went, oh, and the vision was 20/50 in the right eye. And this was the Optomet presentation. And I thought, okay, there's a little yellow spot there. I looked to see if there was any diagnosis of drusen. There wasn't. I see a little bit of pigment epithelial changes in the macula. And so I asked for an OCT, and lo and behold, here's what we have. And you guessed it, the diagnosis is neovascular membrane. And I sent it to Retina, who confirmed it and started him on injection routines. So that was the 10 o'clock patient, and his previous visits to the practice had not included drusen diagnosis. There was no discussion of mitigating therapy, anything that could be done differently. medications and or vitamins, what to watch for. This guy came in for what was down as a routine exam, and he covers his right eye because he can't read at night. So I move on to the afternoon patient. I had a 65-year-old white male, 20/40 in both eyes. This is the Optomat presentation. He had been diagnosed with multiple myeloma 3 days previously. It was a Friday. It was holiday times, and it turns out the oncologist, for whatever reason, said, hey, go get your retina checked. And if there's been any changes, or if there are any changes in your vision over the weekend, make sure you go straight to the ER. Well, this is a Monday, and so I had the patient call the oncologist, and the oncologist was out. There was nobody else to talk to, so I looked a little bit further and got another image. And it turns out this iDEN image is really pretty revealing. He had massive retinopathy in both eyes. He had a macular edema and cystoid macular edema, and he had significantly changed his September visit. And so I said, hey, we can't talk to the oncologist. We kept trying. I'm just going to send you over to the ER. And they tested him until 1:20 the next day, and then released him. Released him after 7 hours of flogging in the ER. And the next day, the oncologist was back, talked to the patient, got the information from him, and admitted him immediately, and he got care. So this is healthcare today. This is trying to cover all the holes that develop in the dikes. And we just need to get a little bit better system, I think. Oh, by the way, yeah, this is the CME on the OCT. Look at that. Right eye is just ballooned out. Left eye cystoid changes as well. He's having these kinds of changes all over his body. So,
hey, David, your pointer works. So if you want to point out some of the, the CME
yeah,
because they can see it. There you go.
Sure, the CME is here, and the cystoid is here, and of course we had changes in the macula, et cetera. So, he just needed to go in, and he needed to go in pretty immediately. And the oncologist saw the difference, so we got him in. But treating is difficult, and so what I try and do in my patients is to identify and then try and modify and change their response to risk and mitigate their problems over time. Pharmaceuticals are really important, and it's really great that optometrists have now the ability in all states to treat most eye care problems, and some even a little bit farther than that. But it's obviously a lot more difficult, and it's behind the curve. So what I like to do, and I think the goal of my eye exams today is what I hear from the patient, and what I really, really want to hear at the end is, hey, I learned a lot about eyes today. And thanks. I really appreciate that. It's not just a prescription for glasses and contacts. It's not just a diagnosis and a treatment plan. It's how do I take care of myself going forward, and what can I do different? So lifestyle, wellness, risk, and prevention is what I think optometry is for, particularly on a primary care basis. We have lots of different specialties that optometrists can be in now, which is really great. A lot of different avenues for practicing, but I'm a family practitioner for the most part, 5 to 95, and I want to try and do the best I can for taking care of them and finding them a path for their lives and their vision. There is a very significant amount of disease that is going undetected and undescribed for patients. And I believe that if an optometrist is not diagnosing a person with a medical condition about 20% of the time on average, that they're probably not identifying, coding, and taking care of people sufficiently. This comes out of a great deal of research from Optos over the years, just in the retina area. But people are walking around with problems that are significant enough that they should be dealing with them and understand better. We also know that ophthalmologists are enormously overworked at this point in time, from the cataract surgeons to the retina specialists, trying to get them to take care of tertiary problems is getting increasingly more difficult. And we need to take care of primary and secondary problems on our own, and not send them funny maculas, and not send them things that are things that we should be able to take care of. We need to send them things that need surgery and treatment that we cannot do or perform in our offices. But we're really needing to do all of that care on our side. I went through the top 20 pharmaceuticals prescribed in the United States on a pharmacy basis. And every time I ran this, it was a little different, but in general, it's about the same. We've got cholesterol problems, we've got high blood pressure problems, we have overweight problems causing diabetes and all kinds of problems there. We have issues with pain, and a lot of that's caused by obesity as well. And then we have inflammatory problems that are also caused by all the other problems that are associated with people getting older and not taking care of themselves well. So look at all these. I mean, they're just kind of a one after the other. There's some thyroid issues, which are, it's just something that happens. But a lot of these are something you can change. But thyroid eye disease is a big problem. High blood pressure, cholesterol, autoimmune diseases, chronic inflammation. And again, if you're not identifying these, probably 20% of the time, probably not doing the job we can do. So I challenge all of us to do a little better and make sure that we're hitting our numbers. The cost of obesity is out of the roof at this point in time. Estimates are 50 to 75% of all healthcare dollars are related to people being obese. And we know that 1/3 are obese and 2/3 are overweight. 25% of Medicare dollars were spent in the patient's last year of life. Macular degeneration, it's costing about $50 billion a year between the 3 or 4 medications that are using for injections. And diabetics, I don't know whether you've noticed this or not, you probably have. I mean, almost everyone's on an SLP inhibitor. It's about $1,000 a month. We have a serious healthcare crisis. So prevention, I'm going to go through from the front to the back. I'm not going to do much on the crystalline lens, but eyelid disease, I think, is maybe one of the biggest things that I've been working on for the last 5 or 10 years, because I didn't know too much about it. And I think with TFOS-DEW study that came out in 2017, they identified that meibomian gland dysfunction is about 80% of the problem in dry eyes. And I happened to listen to a lecture from Don Korb, who is just an amazing person, who gave this lecture in 2021. I've listened to it 3 or 4 times now. It's about 2 hours, and I'm going to reference it so you can look at it yourself if you want. But he talks about meibomian gland dysfunction being an eyelid blinking problem. I think that's kind of fascinating because, and he describes it in great detail in his lecture, but when the lids don't force blink, they don't force close, they wind up having meibomian gland dysfunction because of squamous cell blockage of the meibomian glands. So we'll talk about that in just a minute. But eyelid disease I live in Tennessee now. I lived in Wisconsin for about 35 years. And in my practices in Wisconsin, I would prescribe an oral antibiotic once every 6 months or so for Schlesian, hordeolum, backed up glands, etc. Down here in Tennessee, I prescribe it every week. And I think it's probably because of the growing season in the east, the southeast area, where there's about 50 weeks of growing season, whereas Wisconsin, there's about 2. And because you're throwing stuff in the air, pollen and whatnot, it turns out that there's a great deal of eyelid inflammation. And so we also have, of course, things that are non-lid related that cause eyelid disease: topical medications, glaucoma, histamine, preservatives, poor diet and sleep. But again, the lid related problems, just the mechanical blinking issues that people are developing a lot of times due to screen time. And we're going to talk about this in a minute, but kids are spending 7 to 8 hours on screens every day. This incomplete blinking, the obstruction of the meibomian glands because of this stratified squamous epithelium at the meibomian gland duct. And then, of course, we have surgery, Botox, Graves' disease, myopia, MGD, Demodex. Demodex is off the charts. I challenge you to look at your patients on a serial basis. If you see 15 or 20 people a day, you're going to see 5 to 7 people, maybe 10, have Demodex. And I tell doctors, if you got to prove to me they don't have it. If they're over 50 years of age, they got it. I mean, it's enormous. And the damage that Demodex causes with blepharitis and biofilms inflammation is a huge problem. Now, Dr. Korb in his lecture talks about this, Dr. Bowden, that identified about 75 causes of dry eye. I think we can, every day, this all over the place, you can have lots of different things that cause dry eye, but you kind of got to get it down to a couple of things that are the most important that happen most of the time. I believe that this non-blinking problem and screen time is causing more dry eye than pretty much anything else. So we've been talking about, I mean, when you talk to your patients, what do they say they're doing? Well, I use tear substitutes. How many people are using tear substitutes at $15 a week or a month, or even more than that, spending all this money to just cover up the problems that they're having and just kind of mucking it through? They're not treating the root causes. And Don Corpus talks about the root cause being this TFOS-DO study that found that 80% MGD, not aqueous deficiency. It's outdated. Meibomian gland dysfunction is defined as chronic diffuse abnormality of the meibomian glands and commonly characterized by the terminal duct obstruction. So the dentists have always had this great model of seeing people more often than they need to be seen. Not when your tooth hurts, but every 6 months come in for a cleaning, and then make sure that you're doing prevention at the end of the day. So what we have to do is diagnose, we have to treat, we have to restore, and we have to keep at it. One of the things that I found with dry eye patients is they keep forgetting what they're supposed to do. They get better and they forget, oh, I stopped doing that because, okay, I need to get back at that. I stopped taking my fish oils. I need to get back doing that. I didn't do my brooder mask because, I forgot. I put it in this. I lost it or something. And they just, you have to bring them back every 3 or 4 months because these people it's a chronic problem. It's a chronic matter of care. You can't just let them leave for a year and have them come back.
David, let
So
me
I
feed
found
off
this-
of what you just said there, because the last few
Yeah.
years, I think I've been, last 7 or 8 years studying functional medicine. Joe knows about it. I've been trying to fold it into most of my lectures. But as you go through this, I want to just say to the audience out there, he just said the word chronic, which is I didn't know he was going to say it, but that's where I was going with it. He just finished with that. There's acute and there's chronic. So acute would be someone comes in with a corneal abrasion, someone that comes in, over wearing a contact lens, they have a marginal ulcer, someone has a foreign body in their eye. We all can handle those pretty quickly. Those are acute. It's not tagged to some type of big chronic condition. When you do acute, you can be linear and you can be binary. And when you have chronic, you have to be strategic here. It's more of a strategy. So meaning, and David just said it, the patients are used to things being acute. I was using my brooder mask, I quit. I was using my tears, I quit. I was using my fish oil, I quit, because they're missing that this is a big part of a chronic, and it's a strategy that's being deployed here. And that's why you're, probably as David goes through here, he'll probably talk about different types of modalities because it's part of the strategy rather it being linear and binary. So I just wanted to throw that in there because as you go through this, it's a different way of thinking because Americans were not really good at chronic and strategies. We like things, your sugar's up, give me metformin. Blood pressure's up, give me this. We're not good at that lifestyle change. So I'm going to pause there and let you take it because I'm going to let you run with this because I'm loving this that you're kind of focusing on prevention here tonight.
Well, thank you. And it's a great point that we have been treating and prescribing all of our lives to fix something. You don't fix chronic. You adapt to and you change with chronic, and you continue being aggressive with your continued treatment plans with chronic. So, yeah, it's a different paradigm, and Dr. Don Korb talks about it, and he references the DENS model. And you really have to have these 4 points, but prevention is the one that we're forgetting and missing. The continued follow-up and bringing them back to make sure that they're going through the very basic things that they need to do, that you've told them to do. But I found this slide to be really interesting in the Korb lecture. The myocytes are being obstructed by this squamous cell epithelium right in here. And so it's just blocked off this gland completely. Why do you think these glands back up and get infected? That's exactly why. And so this shedding of this squamous epithelium that causes the obstruction right here is what's the big problem. And this muscle right here, the muscle rhyland, it squeezes with a complete blink. So when I tell people just a couple of basic things to do, I tell them to force close their eyes like this for 2 seconds every now and then. And that actually stimulates the meibomian gland and the rhyland muscle to excrete the meibum if they have any in their meibomian glands. But that's just one little trick to tell people to blink more. I also tell them, most people, they found that most people blink about 1 out of 4 normal times when they're working on a computer. So I tell them if you blink twice as much as you have been, it's only half enough. Think about that. It's only half enough if you blink twice as much as you have been. And then I give them the 20-20-20 rule. And that's, of course, 20 feet, 20 every 20 minutes for about 20 seconds. And nobody's going to do that. And I tell them, we're not expecting you to do that. It's just something, remember, it's easy, 20-20-20. So just look up from your computer every now and then at a distance for a few seconds. And that'll help a little bit. So again, I think the functionality of why meibomian glands don't work anymore is really interesting with incomplete blinking and no blinking that is caused by the screen time on computers. So this Amy Now from NECO did a study on first year students at NECO, and they showed that at a speeds questionnaire that 70% were symptomatic for dry eyes, and only 13% had no atrophy of the meibomian glands, and over 17% had nearly 50% atrophy of the meibomian glands, and 41% were using daily drops. So, I mean, these are kids, basically, young adults. She did another study on 11 to 18-year-olds with computer use. Now, this is even a little bit more scary. They took middle and high school students during the COVID pandemic, and they had about 400 some students, and they had an average speed score of 833. And they were using screen time more than 6 hours a day. I mean, they're using computer laptops in the schools. They're not using chalkboards anymore. They're using computers. These kids are on screens all day. And then when they get home, they play video games. I know, because I got an 11-year-old. And that's all they do is look at screens almost all day, and they don't blink. Most complained about sore, burning, watery eyes, and lots of electronics, of course. People are just not blinking. They're just not blinking, and it causes desiccating stress and MGD. So if you add that to being a little older and having Demodex and realizing that if you have the patient look down, you're going to see collarettes about a third of the time, if not maybe half of the time. And I challenge all of our doctors, if they haven't done it already, to have the patient look down and look for those collarettes. I did it just about 3 months ago, and I was a little shocked. It was 5 out of 15, so that's 1/3. And I didn't prescribe Xdemvy that day because everyone was saying that it was fine. They didn't have any problems with dry eyes. but I do prescribe XDEMVY at least once a week, if not 3 times a week. And as you probably understand, it's only done that often because of the prior authorization protocols that go through. It is a pain to prescribe. But let me tell you though, it is worth it. These people get enormously better by getting rid of their Demodex, and you can scale it on a 1 to 4 scale like you do anything else. And I have seen many people that are the 2s and 3s. I had one guy that was a 4. He came back 3 months later and he was just profusely happy. He said, people are telling me I don't have red eyes anymore. And he'd been working on a solution for years. He was only 35, 38 years old, something like that. XDEMVY works amazingly well, and a lot of people have it. 90%, this is a quote that I got from Paul Karpecki. Was in a lecture, and he said 90% of people that have hordeolum schlesia have Demodex. Now, I was looking for the reference. I didn't get a chance to get the reference for that, so I can tell you what it was, but that's what he said, and I believe him. He's done a lot of the research, so he knows. Blepharitis, inflammatory disease, you got to rule it out. Assume people are on screen times and disrupt their blinking pattern. Observe the lids for scalloped edges, debris, and foaming. You know that that's going to be a hallmark for dry eyes. And one of the things that I've learned after having used intense pulse light for years now is ocular rosacea is extremely common. Telangiectasias of the eyelid is very common in the eyelids, and I didn't quite realize it. And it's kind of like with Demodex, because you couldn't treat it very well. We used tea tree oil. It was kind of caustic. You use lid scrubs. It still doesn't quite work like it should. But now that you can treat it, you see Demodex all over the place. And the same thing with ocular rosacea. Once you start being able to treat it, you see it a lot more often.
Are you going to make any more comments on the Demodex?
On
the the XDEMVY. Sorry.
Yeah, XDEMVY works in the lotilaner. It's about an 85% reduction in 6 weeks. What you do is you prescribe it, and you have people put an eye drop in every twice a day. It doesn't hurt. I used it myself. I'm going to show you with my eyelids here in just a minute. Doesn't sting, doesn't hurt, doesn't cause a problem. You need to use lid scrubs with it. But after 6 weeks, you stop, and it's been lasting 6 months for me. I think it's probably going to last about a year. My guess would be you got to do it every year, but we're going to find out. Lid scrubs twice a day, pretty important, I think. You got to keep doing that. Again, chronic problems have to have chronic solutions. So I think that continues even after the XDEMVY, and then I use triglyceride fish oils. Did you have a question, Greg, about XDEMVY or some comments?
No, I was just going to make some comments that, you mentioned it's kind of a pain in the butt to get, which I agree. Back whenever it was released, it's got a little bit easier now. I think the commercial patient that has insurance will be a lot easier to be able to get, work with the sales rep. They'll be able to guide you. I'm using a local-ish pharmacy in Pittsburgh rather than, I think, BlinkRx when it first came out. I usually tell the patient what I like it for optometry is it's not a chronic, you have it there for 6 weeks. I just tell the patient use it twice a day. Whatever comes out, smear it onto their lids. I have them use it till the bottle's empty. The sales rep won't be able to do that because on label is for 6 weeks. We're kind of using it off label if we tell them to use it till the bottle is empty. And the last thing I like to point out is that it's, it goes after the GABA chloride channel. And that's not really, I remember that, but the key is the Demodex might has that, the human body doesn't. So that really increases the safety factor of this medication and the efficacy and I agree, you get some amazing results with it. So those are just some comments I wanted to make about XDEMVY.
Yeah, no, I'm a fan. I'm a big fan.
And some of my comments are very similar. I'm probably doing about 7 to 10 times a week. You're right. It is very, very prevalent. If it's a grade 1 and they're asymptomatic, I will try the tea tree oil first. But anything above that, I prescribe. Only about half of my patients need a prior authorization, and there's a little bit of effort involved. The other half, their insurance drops it down from $2,000 down to $1,000. But the pharmacy that we use, which actually happens to be in the same city I'm in, it's a specialty pharmacy. They will then apply for a grant, and the whole thing takes about 3 days. But for the most part, most patients are getting it for nothing.
Yeah. I found it to be better over the last 6 months than when I first started. And it possibly is because I wasn't as good at doing prior auths and understanding how the process works. We also have a specialty pharmacy here in Tennessee, in Nashville, and it's Walgreens, and we can actually talk to them, which is nice. It's a lot better than the national pharmacy that was off in Utah or somewhere.
And our local rep she's been with us in different companies, and she's really very good. And I can text her, and she'll run it down, and she'll make sure that the grant is being applied for, and is really very helpful. So it's the support that makes the difference for us.
True. And they do have good support people. Their reps are really well trained. The other thing that I like to use is triglyceride fish oils, and I use a very specific triglyceride fish oil. If you ask me the name of it, I guess I can tell you because of the COPE requirements, but if you don't ask me, then I can't. But this company does all of their products in a triglyceride formation. And I have people use 2,200 milligrams EPA and DHA in about a 60-40 split. And they need to continue that forever. And we'll talk a lot more about how it works and why it works better than ethyl esters, and how a doctor needs to prescribe it pretty much like a pharmaceutical, and what the benefits will be, not only for dry eye, but as well for cholesterol reduction.
Now, Dave,
And
if you
the
want to
other
mention
thing,
the fish oil that you use, you mentioned at the beginning during your disclosures that you're not claiming any superiority, commercial bias. I mean, obviously, you pick your fish oil for a reason. If you want to give that reason out, that's fine. Again, not claiming superiority or bias. So if you want to
no.
mention it, that's fine.
Yeah, no, there's 3 or 4 actually. I use Nordic. PRN is another one that makes triglyceride fish oils. And Carlson, I understand, makes triglyceride fish oils as well. The problem with them is that some of them are not triglycerides. And what I find is patients, they skate and they move. They try and find something cheaper. And if they skate outside of the brand, then that's on them. But if they stay with a brand with like Nordic or PRN, they're always going to get a triglyceride fish oil. With Carlson, they don't always. But yeah, they're all kind of manufactured in the same place, from what I understand. They use hazmat suits and nitrogen environments in Norway, and they chase these anchovies and sardines all over the world. And they're sustainably harvested, so it's a great product, and people really do benefit quite a lot. Hair, skin, nails, it's heart healthy. We'll talk about that as well.
Let
But
me just kind
lastly,
of feed off of what you just said there is, David just mentioned anchovy sardines, and that's really the key that you want when it comes to a fish oil or a company that's doing that, because the anchovy of the sardines eating the algae. The algae then is not eating other fish. So the big fish eat bigger fish and bigger fish. Then what happens is that's when you squeeze and get that oil, you're getting that lead and mercury. So really the key, the company, the company I use is the Pharmanex company through New Skin. David's using his company. We're not claiming superiority, but I went after a company that uses, sardines and anchovies because they eat the algae, and that's what converts it, and that's what they're squeezing and it really minimizes the chance of that lead and mercury type of poisoning.
Yeah, and if you had people take eat as much salmon as they should have to get the EPA and DHA, they probably would get that poisoning and toxins in their system. So you just can't eat enough fish. There's no way to do it. I think heated mass a couple times a day is really pretty nice too, if people will willing to sit down and do it. That's a big thing. And then we're going to talk more about intense pulse light, which is one of the most impressive things I've seen in a long time for eye care. So this is my
And then,
Demodex
and I'll
story.
throw this question out to you right now that came in, and you can answer it how you want, because I know you're going to talk about it. It says, would RF or IPL be better treatment for Demodex and rosacea? I'll let you answer that how you want as this unfolds.
You know, this is my story here on Demodex, and these are my eyes. I had my partner take some pictures. I mean, you can see all the collarettes in each eye. I call this maybe grade 1+ or 2. I've seen a lot worse, but it was definitely significant for me. And I started taking it in September, and I've been feeling a lot better. And I'd used intense pulse light for years on myself. I had my associates do it on me. I hadn't done it for a while, so this is probably a year after my last intense pulse light treatment. Intense pulse light kills those Demodex on contact, but they don't kill the eggs and the just the whole system. So I think you probably, I'm not sure about all this, but I think Demodex works, the Xdemvy load aligner works so well that you wouldn't want to try and just do intense pulse light to get rid of Demodex on a 4+ Demodex patient. But they both help. They're adjunctive and helpful therapies, in my opinion. But I
Well,
don't
it
think
goes,
probably get the
it,
same kind of results you can with load aligner.
yeah, well, it goes back to we're trying to make it linear and binary, right?
Right.
You know, it's better. Well, it's when you have a Demodex disruption, I want everyone to kind of think at a higher level. This is the functional side coming on. But why there's a gut microbiome problem, like we learned about gut microbiome, there's a lid microbiome problem. Why is the lid microbiome upset? And this is now a chronic disease. And now we're going for which is better. Like we're going to do this instead of that. And I'm not saying what our colleague is saying, but I think it needs to be more of a strategy. I think in this case, you know, hey, we're going to do Xdemvy. We're going to eradicate the eggs. We're going to eradicate the bug. We're going to try and do some intense pulse light to get to maybe stimulate, you know, maybe the meibomian gland that was hurt. So I think it becomes more of a strategy than saying which is better. I think, you know, like a bar stool, which leg is better, the front one, the side one, or the back one? Well, they're all important, because if you take one away, the bar stool is gonna fall down.
That's right. And together they're better than they are separately, I'm going to say. So
Yeah.
having said that, though, intense pulse light has been probably one of the most significant additions to my practice in the last 20 years. And the time before that was Optos, and the time before that was, or in the middle of that was OCT and OCTA. But between those 3 or 4 different things, I think intense pulse light is probably one of the most significant things I added to the practice. You know, they talk about dry eye disease being a multifactorial disease, and intense pulse light treats in a multifactorial way. It doesn't just kill Demodex, it heats, it reduces inflammation, it stimulates the glands to work better through ATP production in the mitochondria, and then actually makes the glands work harder and better, and it kills Demodex on contact, the exoskeletons. Now, again, you got to work on the eggs, but if you do the treatment that's recommended for intense pulse light every 3 weeks for 12 weeks, you might catch those eggs as well. But if it were me, and I had a 2 or 3+ Demodex person with MGD disease and dry eye because they wake up in the 3 o'clock in the middle of the morning and they know it's going to be a bad day, I'm going to put them on lid scrubs, Demodex treatment with Xdemvy. I'm going to put them on intense pulse light, and I'm going to do all these things pretty much all at once. The photorejuvenation portion is something that I found to be really maybe one of the more important parts of intense pulse light. And what I found was the third treatment is the one that they actually noticed their dry eye getting a lot better. And why not the first one? Well, sometimes the first one, and that's when you kill the Demodex. The second one, not so much. The third one, they were going, oh, I think I believe you. And the fourth one, they're going, yes, heck yeah. When do I come back again? And because, again, this is a chronic disease, what the answer is most of the time is about every 6 months for a retreatment. Now, I don't need to do the 4-step program every 3 weeks for 12 weeks. which takes, you know, much more time and on their part and my part. But if you hit them every 6 months, most of the people will be better. I had a guy that had rosacea that I was treating every month. That's an outlier. I had some people that wouldn't come back for a couple of years, pretty much have to restart them for the most part because you have to kind of do the whole thing again. But if you catch them and you can keep them on a consistent program, I think every 6 months works for quite a few people. And of course, the heat is instantaneously and significant. So one of the things about intense pulse light, and it's, you know, one of the devices is approved by the FDA for dry eye treatments. And it was the study was treating the lower lid as you do with intense pulse light, not the upper lid, and the lower lid. And so what you do is you go across with this diffuse light about 10 times or so, overlapping across the nose and above, and then over on the other side all the way across. And you do that twice usually. And I don't treat the upper lids. It was found in the study that the upper lid expression on meibum was greater after the treatments than before. So what happens is this diffuse light gets throughout the orbit. Now you use shields. The light that's delivered is between 590 and 1200 nanometers of light. There's a cutoff filter that reduces the amount of light to nothing below 590. But the red light area, which is infrared light, is, I believe, the photorejuvenation portion of the intense pulse light. And because it's delivering this light in this diffuse range up to 1200 nanometers, that's where you seem to get the effective treatment in a multifactorial way. Not just heat, not just reduction of inflammation, and not just killing the Demodex, but also this photorejuvenation. Are there any questions? It's been used for 20 years enough in dermatology, and it was originally invented to take paint off aircrafts. And the Israelis are the ones that figured all this stuff out. It got FDA approved by one company for rosacea in the mid 2010s. And again, like I said before, you can see rosacea more significantly when you know you can treat it. When I walk into a patient, I go, well, you got rosacea, right? Yep, I do. Okay. Have you been treating it? No, I don't. Well, maybe you want to see your dermatologist about that, but let me take a look at your eyes because I think I'm probably going to see it there too. It was approved, by one device was approved for FDA approval for dry eye in 2021. And what I found is about 90% of people got about 80% better after 4 treatments. It was just off the charts. And I started it out with some recommendations from friends, and I was in Vision Source, and they said you should get it, and it's kind of following the trend. I used it a little bit sporadically, and I found that people were getting, this was 2018, and I found out people were getting up really quite a bit better. So I had to find out how it worked, and it took me a little while, but I think I finally figured out this multifactorial portion of why it works so well. And then I repeat every 6 months.
So before you move on, for the people that are not doing intense pulse light, because there was a handful that are, basically, if you think about it, the intense pulse light, it goes after 2 pigments. It goes after red and it goes after brown. Those are the filters that are out there, typically for intense pulse light. So when you look at the screen, there's usually things for vascular, and our one attendee asked about rosacea. I think it's really, intense pulse light is great for rosacea when you use the vascular side, because it's all kind of programmed to do that. Then you got kind of a pigmented side when you go after the different types of pigmentations that you might want to be trying to smooth out, maybe from a cosmetic purpose. Then in between, there's these skin treatments, which are kind of a red and a brown that's in there. So when it comes to intense pulse light, and the filters that David so well went over and talked about, the range of 590 to 1200, red and brown is what it's going for. So that's kind of the dynamic of that, and it works well. I have it in the practice. So everything you said, but I just wanted to clarify for those who are here for education about intense pulse light that don't have it, reds and browns.
And then there are 2 new devices, radio frequency and muscle stimulation devices the RF heats the meibomian glands in a more significant way even than intense pulse light does, and it promotes this tissue tightening, inflammation reduction, water reduction. It's also got an aesthetic value as well. You know, it takes care of wrinkles, and people seem to be pretty interested in getting rid of some wrinkles. One of the important parts about radio frequency is that monopolar RF mitigates the risk of arcing. If you have a bipolar device, it's going to have an electrode basically that has stimulants on both sides, and if you don't touch them at the same time on the patient's face, you can get arcs and get a little spark, and as well like a shock. So monopolar is in my opinion the way to go on RF. This isn't a talk about really just radio frequency and dynamic stimulation. It's just kind of a broad overview. I think IPL is a really big deal. I think dynamics muscle stimulation could be a really big thing too, because we all know that the lid laxity of patients' eyes changes greatly over time, and is probably half the reason when the lid hangs down, the meibomian glands don't work anymore, and the tear system doesn't work very well. So this stimulation really does seem to work very well. It just came out last year for Eyecare, or just last month, I'm sorry, for Eyecare. So here's the polling question.
Okay, let me launch that.
While that's going off, David, a comment came in, not a question, but a comment that a person uses doxycycline or a Z-Pak for dry eye. What are your thoughts on that?
Doxy works nice. I think that I find a lot of people are not real interested in taking a long-term chronic antibiotic.
Mm-hmm.
And because it isn't completely, it's pretty effective, but it's not completely effective. And because I have so many people that don't want to take Doxy like that, I don't use that. Now, the other one was what? Oh, Z-Pak.
A Z-Pak.
Yeah, Z-Pak, that's good for all kinds of things, but I wouldn't use that very often.
Actually, David, what I use, I don't use the Doxy either for that reason. A study came out a while ago that looked at using a gram of azithromycin once a week for 3 weeks is as good as Doxy twice a day for 6 weeks. So that's what I do.
Wow.
And I have to explain. I have to explain to the patient. It's a weird dosing schedule, but you're going to get two 500 mil. You're going to take two 500 milligram tablets once a week, every week for 3 weeks. You're going to get 6 pills, and it's as good as 6 weeks of Doxy.
Huh. And is it long lasting, or is it?
It is. It is. I mean, you can go a second dose if you have to. Generally, I don't do them sequentially though, and that's what the corneal specialists in our practice use as well.
Interesting. Yeah, I hadn't heard that.
Yeah, they both work. It inhibits the lipase enzyme. And so the key here again is that it's going to just be part of that strategy when you ask long term. So it's part of the strategy that you could use. It's great for rosacea, but then you're probably going to fold in your intense pulse lights and all these other modalities that you're talking about. If we just use that and say, okay, you're going to be fixed forever, you'll probably have a failure on that.
Hey, Dave.
All right.
Hold on, before you do that, another question came. Any contraindications, David, for RF or IPL treatments?
Not that black patients should not, so skin type 5s are not able to do IPL. RF, there are no indications that I'm aware of, and in dynamic stimulation, no pacemakers.
And when it comes to the IPL, like, you know, in a black patient, there's lighter skin and darker skin. You can do some lighter skin, so they're not all excluded in a sense. And
That's why I said 5 at the end. Sorry.
Yeah, that's okay. No worries. I'm just clarifying it. And you could do a test spot is what you would do if you wanted to make sure. So
it's a great way if you're concerned.
Yep. And so, David, your audience is paying attention. They said 90% at 54% said 90%. And what percentage of patients with a hordeolum have shown to have Demodex.
I tried to make it easy. I want to make it, so it's Sunday night, so
Yeah, exactly.
make it easy for people. All right, so moving on, further information that quite a bit of the information on improper blinking was from the Don Korb lecture that if you text me or email me or contact Greg, I'll send you this link so you can listen to it. It's about 2 hours. Really, really good. And then there was a recent article from Laura Perryman, who I find to be extremely helpful in the area of dry eye. She just came out with an article, and I believe it was a review, or maybe it was optometric management, managing dry eye in 2025. If you put that into your Google search, you'll find her in that article. All right. Slippery facts of fish oils. So a friend of mine, Larry Alexander, some of the old folks would probably remember Larry Alexander. He was an important practitioner in the area in Alabama and Indiana. I remember him all over. He worked with OCT and OptiView for quite a long time, but he was hearing about this slippery facts of fish oils a bunch of years ago. And he said, I'm just going to sit myself in a room and just figure this thing out. And he wrote this article that was in Review of Optometry in 2012 about triglycerides versus ethyl esters. And what he found was that they're not at all equal. The body does not absorb and work with ethyl esters like a triglyceride. And he found that you could get that effectivity by dosing it up about 16 to 20 times. But at the end of the day, you probably smell like a fish. You really wouldn't want that. So I tell people not to take ethyl esters, that Costco jugs of junk. It basically challenge a patient. If they're taking a fish oil they think is really good, cut the capsule, sniff it. If you want to eat that, then go for it. An ethyl ester will not smell good, and you will not want to ingest that. Triglyceride fish oil will smell a little bit like lemon. You'll catch a whiff of fish, maybe, but not typically. And the reason for it is because it's been reorganized, basically, in this nitrogen environment. Oxidation and oxygen in general makes fish rancid. It's just like putting fish in a refrigerator for 3 weeks. It's going to go rancid. When the fish oil ethyl ester comes out off of the manufacturing line, it's rancid because it's been exposed to a great deal of oxygen. So again, it's about triglyceride digestion is about 1.7 times higher. And if you want or have a patient that's interested, you measure their lipid panel or the omega-3 blood index. You'll find their cholesterol is reduced between 10 and 20%. If they're not taking a statin already, if they're not taking a statin, it'll reduce about 10 or 20% over a 3-month period of time. And the HDL will increase and the LDL will decrease. On the omega blood index, you go from about 2 to 10%. Most everyone, if they don't take a supplement for fish, will run about 2% on a blood index level. It's about $150 to do an omega-3 blood index. Lipid panel, I'm not sure, but usually it's covered by insurance. And of course, you want to take it with a meal best you can. Again, if you take it with a high-fat meal, you're going to increase your triglyceride percentage as well. So that's my thing on fish oils and for dry eyes. Just talk a little bit very quickly about the crystalline lens. I'm going to bypass the crystalline lens because I don't know too much about reducing cataract formation, unfortunately. I know that Vuity didn't help my presbyopes very much a few years back when they started prescribing pilocarpine again. That didn't make too much difference. I had about every other day somebody asking me if I could prescribe it for them, and they found out that marketing was really successful, but not so much on preventing cataracts, to my knowledge. Now, you guys might know more about that. Is there anything coming around the pike that's going to reduce cataract formation?
I'm not aware of anything that is compelling right now, Greg.
No, there was a couple of the presbyopia drops that were out there, or one of them in particular that was working in the cross-linking, and they were talking about how it's reducing the formation of cataract, but I haven't heard that much noise of that medication for about 4 or 5 years now. So it's probably falling off.
Yeah.
So
Well, I ran across this article the other day, though, about cataract implants. And I happen to have retinal detachments a few years back, and one in both eyes, and then had cataract surgery in both. And it turns out that I didn't know too much about how that developed. So, not talking about prevention at this point, but this doctor in the 1940s, right after World War II, there was a pilot that was shot down, and he got plastic from the canopy in his eyes. And this ophthalmologist who was seeing him couldn't get all that plastic out of his eyes. And he thought, wow, that eye is not reacting to that plastic. I wonder if I could maybe take a cataract out and put an implant in with that kind of plastic, if the patient wouldn't respond with inflammation to it. And turns out that this ophthalmologist worked with a company that developed plastic lenses, and he got pretty good at doing it. And then he was turned away by his profession and retired in 1971, thinking he was a failure. Have you guys ever heard of this story?
No.
I hadn't heard of it either. So it turns out that in 1980s, down here it says 1980s, a group of new generation ophthalmologists became comfortable with the operation, and then in 1990s it became standard of care. He died in the gentleman that actually invented it didn't make a dime off of his invention from patents, but he did die at 94 with understanding that everybody was getting cataract surgery, and today 26 million people get cataract surgery. So thinking outside the box, taking a look at somebody and saying, huh, they're not reacting to that plastic that's in their eye. I wonder if I could maybe, it was the first time actually that they ever did something to implant something that was taken out in all of medicine. So they hadn't done hip replacements, they hadn't done knee replacements. This was before all of that. I just thought that was pretty interesting.
yeah.
So hopefully y'all do too. So one of the things that I've been thinking about over the last few years too is vitreous floaters. It has a real impact on vision. Everybody comes in saying, I got floaters. I mean, everybody. And we kind of poo-poo it. And I don't remember studying it very much after school. I haven't been really thinking about it the last few years. But I was in a lecture at UW, and they were talking it was a Grand Rounds for UW ophthalmology, and they were talking about vitrectomies versus vitreolysis with YAG lasers. And the retina specialist said, we really ought to not poo-poo these guys too much. These people are really searching for something that we should really try and think about fixing. And I thought it was kind of insightful. He said he didn't really want to see people doing YAG lasers on people, but maybe because of the relative safety of vitrectomies, that it ought to be considered a little bit more often for people that have significant problems. Well, I thought, wow, that's kind of eye-opening to me. The retina specialist would think about doing a vitrectomy for floaters. But again, everybody we see sees, has these problems, and it does cause lots of troubles. And there's a study that shows that 37% reduction in photopic conditions and 25% in mesopic conditions. There's a nice study, it's down here at the bottom, impact of symptomatic vitreous degeneration. It was done, it was published, a few years back. But people go at great lengths to get these problems solved. And you think about it, it's pretty big area, the back of the eye, and we haven't really been paying too much trouble. There's collagen fibers and hyaluronic areas, and they cross-link, and there's significant stuff going on there. And so we should really look at this, and we should not just look through it. We should look at it and see what's going on. It's about 4 millimeters filled with collagen fibers, glycosamine, glycans, proteins, trace metals, quite a few trace metals, by the way. There are 3 areas: the vitreous cortex, the area of the internal limiting membrane, the central vitreous, and the vitreous base. So it functions as a shock absorber, makes sense. It contains a lot of nutrients for the retina pigment epithelium and ciliary epithelium. And we know that it liquefies and it degenerates over years. Starts in the teens. Everything starts in the teens, start decaying in the teens. And by the 8th decade, it can be very significant. So what causes this degeneration? Well, it's stress, oxidative stress, and enzymatic induced liquefaction. And it can be non-enzymatic or enzymatic. Cleaves the collagen by metrics metal protein, MMP. And here's all the stuff that's been identified in the vitreous. Various antioxidants. There's ascorbic acid, riboflavin, cysteine, tyrosine, uric acid, taurine, selenium, zinc, a lot of antioxidants. And it breaks down over time. And that causes this liquefaction, and then the strands come together and they keep people from seeing the way they want to see. So there was a study was done by John Nolan in Ireland, small study, but was placebo-controlled trial. And they used a supplement that had lysine, vitamin C, some zinc, and some citrus, or I don't even know how to say that, aurantium. But it measured the change in visual discomfort from the floaters, assessed by the visual disturbance questionnaire. And then they also took pictures. They took OCT pictures. I'll show them to you in just a minute. Pretty interesting. They reduced the floater size as measured by up to 2/3 after, I believe it was 6 months. But secondary outcomes, best corrected acuity, letter contrast sensitivity, photopic functional contrast sensitivity, and positive negative contrast polarity. Basically, after supplementation, the active group reported a significant decrease in their visual discomfort from floaters. That's kind of significant. So here's a question.
So the polling question is open for those that need to find it. Over on the right side, you'll see chat polls. And the question is, why does the vitreous degenerate? Ooh. Oxidative stress, antioxidant activity, enzymatic activity, non-enzymatic activity.
David, in your practice, how often are vitrectomies being done for floaters?
None in my practice, because I'm not sending them over. But I don't know what they're doing when they see them. Do you have any studies, any thoughts on that?
Well, in our practice, we have a retinal specialist who will do it if the patient is pseudophakic.
Oh.
He won't do it if they're phakic, though.
Well, that makes sense.
So let's chat about that. I was kind of going to wait to the end there, as we'll do this as the polling question is. So every time you do a vitrectomy, the patient always forms a cataract. And David's talking about all the different antioxidants and protection. So the vitreous gel is super protective of the crystalline lens. It's a nice buffer from what is going on in the retina with all that light being captured, photoreceptors going off, the byproducts that are being produced. And what happens is whenever you have the vitreous there, it acts as a buffer for the crystalline lens. When you take out and do a vitrectomy, they put in, BSS, balanced salt solution. Basically, then that gets replaced by aqueous over time. Now you don't have that barrier there, and that lens gets bombarded with all those free radicals, and then it creates the cataract. That's why you always see that cataract formation, and that's why Joe's practice does not do a, unless they want. I mean, patient just has to know they're going to get a cataract, but he'll do it for floaters if they're pseudophakic. In retinal detachments or macular holes, they always form a cataract 6 months because that retina is got a ton of free radicals. All right, so your answer is 72% oxidative stress. And then we went right down the line at 12%, 14%, and 2%. So antioxidant activity, enzymatic activity at 13%, and non-enzymatic at 1%. So 73% said oxidative stress.
Yep, that's the answer. So yeah, the other three are things that actually help it not degenerate. So the antioxidant activity, enzymatic activity, all help reduce that. So we're going to come back to a little bit about a product that can be used with the study that was discussed, and it is in commercial formation. If you ask me the question, I'll tell you where it is. But people really seem to like the idea of taking it. I have not used it long enough to find amazing success with it, but like I said, the studies were very impressive that showed it made a big difference. So talking about the retina, now we're going to go back to the retina. Wide field imaging, as I discussed before, kind of changed my life as a practitioner because I would find things that needed treating, and I was working on a wellness basis. So screening to find pathology and make a difference by changing the habits, attitudes, and treatment plans for the people that I was seeing. Wide field imaging has gone through some phases that I think are really pretty interesting. You can separate the retina from the choroid, and you can use autofluorescence to see the RPE. We're going to talk about electroretinograms in practice. When I was in school, I'd learned about ERGs, and I think the device they were looking at took up almost a whole room and required electrodes that you put on the eye and the back of the brain. And I said, note to self, I'm never doing ERG. Well, there's today a device that's handheld, and it takes 1.5 minutes per eye to do some pretty significant electroretinogram testing for glaucoma and diabetes. I think they're really pretty helpful on a primary care basis for those things. And then, of course, we have ocular coherence tomography and OCTA. And there's a new code this year for OCTA, which is really, I think, a nice thing, because it was, I don't have it currently in my practice, but I did have it when I was practicing in Wisconsin a couple of years ago, and I used it quite significantly for macular degeneration. I thought it was really pretty helpful. So wide field imaging the retina, what is that? Well, we probably all know what that is now, and there's different levels of wide field and ultra wide field based upon the devices that are used. And one of the things that people would ask me when I was trying to talk to practitioners about how different it was in the experience for a patient, they'd say, well, are you just getting rid of your direct or your 90 diopter or your 20 diopter? And you never do that. It's an additive piece of technology that you can look at things differently. And one of the things that I worked with Optos quite a lot about was making sure that we understood that dilation still was really important. And in fact, both were better. So one of the things that ultra wide field done in the beginning would be able to give you a roadmap to find the disease, utilizing the map of the retina to go look more significantly with something like a 90 or a 20 diopter lens in the periphery. So it's an adjunct technology that gives you a different field of view and more options in general. But there's wide field and ultra wide field, and then there's slit lamp technology. Charlie Scapins was an ophthalmologist, was selected as one of the 10 most influential ophthalmologists in the 20th century. He invented the indirect ophthalmoscope, which we all use today. And it was invented in Belgium. He was a Belgian ophthalmologist, and during World War II, it turns out he owned a lumber mill. And what did he do with that lumber mill in northern Spain? Well, he processed and got Belgian Jewish people out of Nazi Germany and to freedom, and he protected them. And he spent 3 years operating this lumber mill during World War II and was able to escape being caught and jailed by running out the back of his house and leaving his wife and children in the hills. And he got to England, and after the war, he was reunited with his wife and children. But he went back to Belgium, and he said, I have this idea. I think I can take a look at the back of the eye with an indirect ophthalmoscope And the Belgian people said, we don't need that here. And so he said, I'll go to America. They'll like it there. And sure enough, he did. He went to Boston and he founded the Scapin Institute in Harvard, pretty much the predecessor to all of retina specialists in the United States. So why do I say Charlie Scapins is interesting? Well, he happened to be at one of the shows for ophthalmology when they were doing tattoos of the eyelids. And he was at the Optos booth and he looked around. He said, all of that is junk. This is where it's at. He was the guy who invented the indirect ophthalmoscope, and he understood and realized that wide field technology and the ability to image the back of the eye would change the world of retina. And now it has. It's really pretty amazing. One of the things that has happened with wide field imaging is that we now have a way to have the gold standard repeated of 7 degrees of fields in film. Back in the day, in the 70s and 80s, there was regular real film, photographic film, that would be used to take a look at these 7 degrees. And that's how diabetes was studied and managed over decades. Well, when film went away, there were only digital cameras, and it was found that the instruments that were using this laser technology, red and green filters, were as good as film in 7 degrees, 93% correlation, whereas digital cameras were only 89%. And that was done by the Joslin Institute in Boston. And it was found that what they wanted to do is they wanted to have wide field imaging capabilities all across the country and all of their retina reading centers. That's one of the results of this study that was done in the late 2000s, early 2010s. Further, in 2015, it was found that if you have predominantly peripheral lesions, now I'm using my pointer here, this patient here that has diabetes doesn't have much of anything going on in the central 7 degrees, but there are predominantly peripheral lesions here. There's blot and dot hemorrhages in the periphery in both eyes. And it was found that over a 4-year period that those people who were found to have these predominantly peripheral lesions were 3 or more times greater to develop another level or 2 of retinopathy within the next 4 years. So in your diabetics, if you're seeing people, my advice would be think about this and look at this and realize that if you have a diabetic you're seeing and they don't have much going on in the center, but they do have peripheral diabetes, they're significant for risk and you need to bring them in more often. My guess, my advice on this particular patient would be every 6 months. If you just see just a casual dot or blot, I would definitely make sure they come in every year, but possibly every 6 months as well. So further, it was found with ultra wide field angiography. Now that's using the contrast dye, that non-perfusion in the periphery resulted in a great deal of central problems and again diabetic retinopathy progression. So one of the other things now we're seeing is that retina specialists are lasering not just pan-retinal, but they're lasering in the periphery to get rid of this non-perfusion in those areas to reduce central macular edema. Joe, do you see this? Do you guys have you still using angiography in the practices you're in?
Yes, we have a retinal specialist, and he does fluoresceins
Okay.
very, very frequently. We have a retinal specialist really a walking distance from my satellite office, and he was telling me how he has an OCTA now, but doesn't quite know what it means or how to use it.
Oh.
But one thing you said earlier, I want to talk about when you say how wide field imaging is an adjunct to our clinical examination. I think that truer words have never been spoken. You really still have to examine the patient. And David, I do a lot of medical malpractice work as an expert witness. I can think of 2 cases. one involving an OCT and one involving wide field, where something was detected, but the patients they weren't actually clinically examined. They weren't dilated to confirm, and the assessments on each of them were wrong. Both were retinal detachments. One was thought to be central serous, the other was thought to be a retinal tumor. Maybe all this could have been obviated had the doctors gone a little further and actually examined the patient. So, yeah, they did pick up pathology, but they misinterpreted the pathology with the wrong management, and they were two malpractice cases. And ultimately, I had to walk away and decline to defend them because I didn't feel the care was standard.
Yeah. We all know cases like that. It's sad. You gotta be awake all the time, taking care of people. It's not easy. If it was easy, everybody'd do it. So you got to be thinking. Autofluorescence is also a very helpful tool, and now something that can really be done very easily for AMD, uveitis, tumor, central serous. What you're seeing when you see black is dead, when you see lit up areas that are right here along this edge, that's dying tissue, basically. And so the general static is fine. Black is dying, and lit up is general is the static is normal. Black is dead, and then this is dying. So this geographic atrophy is expanding. That's the bottom line on this particular slide. It can give you some very helpful things. Everybody has drusen over 50 years of age, just like Demodex, unless you prove to me that you don't have it. So take a look around and keep looking, because probably if they're over 50 years of age, they're going to have signs of retinal degeneration. And there's a study that showed it was about 57%. Now, this is a Reykjavik study, pretty homogenous group of people, but at the same time, sorry. Oh, that was just noise. Anyway, so a lot of people have drusen. I think people need to know that they do have the signs of changes in the retina, and I think it's important from a patient care standpoint that people don't think that their eyes are inert and not subject to change over time and age. I tell people pretty much every day, if you line up a 20-year-old, a 50-year-old, and a 70-year-old crystalline lens, and I don't know how old they are, I can line them up just fine. Same thing with retinas. Retinas look pretty much the same change, 20, 50, and 70 years of age. You're going to be able to line those people up because they age, people age. And we're not getting out of this alive. So we just got to let them know there's some things you got to do if you want to enjoy it as much as you can. There was a sub-study at the end of Eyelids that was designed to measure the number of people that had peripheral lesions who had macular degeneration. And it was found that 97% of people had peripheral drusen. And that it was, I think this was a 570. I was thinking it was 1,000, but it's 570. But a very significant number of people were studied on this and the OPERA study. And they found that pretty much everybody that has macular degeneration has peripheral degeneration. Now, they didn't show and prove that the precursor to macular degeneration is peripheral degeneration. But in my practice and in my experience, I can pretty much tell you that it starts in the periphery in most people and starts popping up in the center as time goes on. And so it's a pretty much full-on retina disease. You can think of aging as kind of an oil slick in the back of the eye, and the droplets of oil and the puddles of oil being drusen. Those are the ones you can see. But that's how people change with their age. And so the people that do have that probably or likely will become their parents and develop the macular degeneration that they're telling you that they have experienced, and they don't want that. Polling question.
Okay, the polling question is
You're
open. Joe, if you
you're
want to
caught up?
take the,
all caught up?
all right.
Nothing,
Well,
nothing in the chat.
wide field imaging is superior to all other forms of fundus imaging and should replace other methods of viewing, such as 90, 70 diopter lens examination. True or false? So find this to make this synchronous and interactive over on the right side there. You'll see polls. Click on that and it will be open and you can click true or false. All right. Well, I think we have the trend down here of 91% are saying it's false. 90%, 10% saying true.
Yep. Just gives you another tool in your bag. It's a good one, but it doesn't replace other instruments. I just used a direct scope the other day. I kind of like it. Don't use it much, but I do it every now and then. Are
Well,
we
the
ready
other
to go on,
day
Greg?
I pulled out a pressure patch on someone and needed to do it. And it was like dusting that out of the toolbox, but it worked very effectively. So
Yeah.
Dave, what was it? What was the cause to use a direct ophthalmoscope for you?
Well, I was trying to see whether or not a patient had a young patient was a hyperope or not. It's a little trick. You look at the back of the eye, and if you see a +5, that's a problem. If you can see the fundus at a clear letter +5, that's a problem. They're +5.
Have you ever used your direct to do monocular indirect ophthalmoscopy?
No, I can't say that. I remember they used to have one of those devices that was like long, and you could use something like that, but I've never tried to do it that way.
Greg, have you?
I have not. I've heard it talked about, but I've never done it.
Yeah, I mean, I generally don't do it because if I'm going to do an undilated 90, but you can take your 20 works undilated, dilated, but certainly undilated. You can take the 20 diopter lens, hold it, take your direct ophthalmoscope, click it to about a +3. Now, if you go a little closer, you increase the plus. You come back a little bit, you decrease, and you should get a pretty darn good view of the optic nerve and some of the vasculature. And if the pupil is large enough, you can follow it maybe up to the mid periphery.
Nice. It's good stuff. Little tricks.
Yeah, for that patient you don't want to get too close to.
Yeah, there's a lot of them. So one of the nice finds over the last few years is the kind of a re-understanding of electrophysiology and glaucoma and diabetes for me. They came out with this handheld device, and like I said earlier in the lecture, I said I kind of noted to myself when I saw that big room for an ERG is never going to happen in my practice. I'm never doing that. But this handheld thing seems to really have a nice correlation, in particular, in my opinion, in my experience with the GCC part of the OCT. So I'll talk about that in a second. When we see glaucoma, of course, there are damages to the ganglion cells. And when optometrists see patients, we're not taking somebody that's nearly blind and trying to find the third medication or surgical method that's going to keep them seeing for the rest of their lives. What we're doing is we're seeing a 35-year-old who has a family history of glaucoma and pressures at 25, and we wonder if they're going on a bad path. And we're trying to find the earliest need to intervene in that patient or not. Who wants to be on medications for 30 years? It probably won't work that way as time goes on, but at the same time, a young patient is not going to want to be on a chronic medication forever. And we're trying to figure out whether they just need to be followed or whether they need to be treated. And that comes down to change over time and whether or not that pressure is causing damage to the optic nerve. Well, or optic nerve, and or before that, the ganglion cells, or before that, the bipolar cells. So this ERG waveform has three waves. The photoreceptor wave, which is where the photoreceptors, how quick they are to respond. I got the arrow here, how quick those photoreceptors are to respond or not. And then the B wave, which is the bipolar cells, how quickly this signal moves from the photoreceptors to the ganglion cells. And then the PHN, which is the one where the ganglion cells are affected, getting the signal from the ganglion cells to the brain. And any deficiencies of those can have certain effects and be very helpful to understand and lead you to more testing. So the protocol for me is pressures of 25, funny optic nerves, history of glaucoma, all three, and doing a PHG and seeing if they have a lag on the B or a ganglion cell problem. And it's surprising how many people, when I see those signs, the pressures being up or not, that they might have a little deficiency. Nobody's the same, as you probably understand. But it's a little surprising. And when I bring them back, then I do the full workup on visual fields and OCT and whatnot, visual fields. So you can also do other kinds of problems in the retina. I have not done this in my practice, but again, because the test is so easy and there's so many different things you can test for retina problems, I think it has some real value in clinical practice. Let's see, I did the G's, yeah, the ganglion cell function, right? Even more so, I think the diabetic patient, which there are so many of them now, can be functionally helpful for knowing a risk and determining whether or not somebody needs to come back a lot or not much. I had a patient that's kind of interesting. He was 61 years old, black gentleman, came into the practice about 3 years ago, and he came in for something that was a vision issue. He just didn't feel like he could see as well. I couldn't remember what it was, but then I saw that he was diabetic, and so I thought, well, I had this new instrument, I'm going to test him on it. Well, I did the diabetic report, and this particular instrument that I use, if anything is over a 23.5, they're supposed to be sent in or looked at quite a bit more. So this gentleman was 24, and I went, wow, oh, okay. That seems to be pretty significant. So I thought I'll send him to Retina and see what they think. He didn't have much retinopathy that I could see, but I followed up with a retina specialist, and that retina specialist was on maternity leave. And so I talked to a friend of mine that was there, and she said, well, he had a vitrectomy 3 years ago. The guy didn't tell me in the chart. I didn't have any information that this guy had a vitrectomy, but the damage was already done for this gentleman. And he had the kind of report that I would see on a very significantly affected diabetic retinopathy patient. He was more like this flat pupil response that you see down here where I'm putting the arrow down there. He didn't have much retinopathy because he'd had a vitrectomy and had been treated. So I wasn't seeing disease on the fundus, but I was seeing disease because of the measurement of how the photoreceptors and the pupil were working in combination. So I thought that was pretty helpful and interesting. Have you guys used full field ERGs?
I do not. I've been playing around getting it in the practice, but I meet with Redival quite a bit. I just saw them down at Vision Expo East, and I think it would be great, the early detection and all the prevention that I do, to have it into the practice. It's just having all, I have so much stuff right now. How do we fit it in?
No,
I think it's
get
a
it.
great test.
Yeah, I think it's a great test. It's very quick, it's objective. Patients don't have to do anything. They just look into the device, and it takes a minute and a half. And it gives you a pretty helpful information. And what I found in particular for the glaucoma patients is that the GCC correlated pretty well with photoreceptor functioning in the ERG. So if they showed me that it was bad, it was usually bad on the GCC.
The comment that I like to make is that, we all think in glaucoma specifically is that we think that structure versus function shows up first in glaucoma. And I always couch that. And when I do a live audience, everyone says structure, structure, structure. And it's structure based upon what you have in your office. Because right now, I mean, meaning you, the audience, not you, David, but you have a visual field versus an OCT. Yes, you're going to say OCT structure, but if you start putting in this ERG testing and you and the and even the Raven color cone contrast test, I have that in the practice. These are both functional tests and they could pick it up before the OCT. So you have to be careful whenever you answer that question. People always go structure based on what you have in your practice, but ERG and the Raven cone contrast test can pick it up. And those are both function tests that can pick it up before the OCT. So, it's just how much equipment can you have, right?
Yeah, that's true. I have seen a lot of B wave reductions that don't wind up with ganglion cell function, PHNC or whatever, PHNG. So I'm wondering if that's the precursor to ganglion cell dysfunction is bipolar cell problems. But I don't know. That's just throwing stuff out.
Yeah.
So this retinopathy algorithm in ERG incorporates the pupil response, and 23.5, like I said, or more, is about a 11-fold increase in intervention in 3 years. So the studies show it's a significant development to have a retinopathy score greater than the 23.5. So it's reimbursable, takes a couple minutes, very simple, it's objective. Works really well and correlates nicely with GCC, in my opinion, and my experience. So here's a question.
And you're still caught up with the audience questions.
Cool.
You're good, David.
Cool.
And I have the polling question open, and it is: with ERG, the A wave is bipolar, photoreceptors, ganglion cells, not relevant to patient diagnosis. And the answers are rolling in nicely. David, you have about 11 minutes. I think you're looking at the handout earlier. I think you're right on time.
Okay.
Just FYI,
Thank
as
you.
this polling question is rolling in. And I'm going to display it. We have 16% saying bipolar, 53% saying photoreceptors, and ganglion cell 31%. If you want to just kind of hit real quick, maybe go back to your slide and hit this so that they can see what you're chatting about, since this is relatively new, that'd be great.
Yep. So yeah, the A wave is when the stimulus hits the photoreceptors. The B wave is when it's transferred from the photoreceptors through the bipolar cells to the ganglion cells, which is the PHNG wave. So the answer was A is photoreceptors. First thing it hits. PHNR. And then PHNR is the ganglion cells. Yeah, it's new and I went over it pretty quick. But yeah, take a look at it and see what you think, because I think it's going to have some real significance.
Yeah, Mike Simber's in my area. He loves it. He's kind of the guy to go to whenever I have any questions on it. He's been using it for
Me too.
years, and yeah, he's definitely he's all
Yeah, I had
about
one. I
doing
ran
this.
by him a couple months ago. I talked to Mike all the time.
Yeah, he's a
So,
great resource.
So here's the kind of the end of the program here: prescribing eye supplements for wellness. And we talked about the idea that we got to get ahead of this disease problem. And what do? Well, there's some habit kind of changes: exercise, diet, not smoking, things like that. There's some additive programs for supplementation which are pretty significant, in my opinion, starting with triglyceride fish oils, but not excluding carotenoids. Carotenoids are really very important as well for lots of different things, including cognition and reduction of dementia and Alzheimer's. But I'll go to that in a second. And then lastly, this vitreous floater program, which I think the supplement could be something that people might really like a lot because they're visually suffering from floaters. And I tell people, take it for 90 days. If you don't see a difference, stop it. Study said 6 months. Maybe give it that. But if you don't think it's making a difference, then just stop that one. I haven't gotten years of experience like I have with triglyceride fish oils and carotenoids. I've been doing that for more than 10 years, 15 years now. And I've seen some very significant changes because of carotenoid and fish oil supplementation. But I find that doctors don't always want to do it. And I think we should prescribe these just like we do pharmaceuticals, because they have the same effect. And there's a dose response effect, just like pharmaceuticals. Now, you can't ever take everyone on this ride. There are some people that just will not do it. But I'm finding that more people are interested in healthy choices and holistic ideas as opposed to pharmaceutical medications. And again, I think pharmaceuticals are great when you're treating something, but trying not to get the disease is a whole bunch better. I think it's important to emphasize the reason and the need prescribe as you would a dose and an amount and a time frame. And then you need to back it up with research. And there's some significant research today that shows that they will benefit from taking supplements. Allowing people to understand you're not trying to just sell something to them. They can get it somewhere else. You can get it on Amazon. You can get it at Whole Foods. You can get it in places. And you just need to get it so that you keep taking it, because again, you need it pretty much all the time. And if it's not convenient for you to drive 20 miles to the office, we understand. We'll try and make it so that we can send it to you if you want, or you can get it somewhere else. And that seems to relieve people in a significant way. So if you're going to start prescribing supplements, I think it's important to give people choices and keep them from having to have them purchased from you. I've talked to a lot of doctors that seem to want to have them purchased from them only, and I don't find that that's the most relieving patient experience. They seem to kind of just relax a little bit when I tell them they can get it other places, but if it's convenient, get it here. Certified supplements are also important because, as you know, over-the-counter nutraceuticals are not verified typically, unless they self-verify through independent testing. And all the products that I use are independently tested. And then emphasize the OCT nature and your prescribing criteria. So the three that I do are carotenoid, vitreous floater supplements, and triglyceride fish oils. Basically, you can use information that the patients are concerned about and bring up. There's a lot of information about blue light glasses and the need for blue light glasses with screens. I think it's better to put carotenoids inside your eye to block blue myself. That's exactly the way I tell them. They think their vision is off, but there's no change in the refraction. We know that lots of dry eye patients have lots of troubles with their vision, and it's very, very sporadic and very changing. And then, of course, a lot of times they complain about night vision problems and glare. When you find things, sometimes what you find are drusen, and you find that patients have had cataract surgery, and you find that people have history of macular degeneration. We didn't cover it today, but there are ways of testing your dark adaptation effects, and we're finding more and more people with retina diseases are having troubles with night vision earlier than they otherwise would. Why is this? Well, because the retina is degenerating. And some happens more in some people than others. And it's not just the cones and the macula that are causing macular degeneration. We know the rods are degrading as well. People ask, well, I use the computer all the time, as they can get those blue light glasses. Well, some blue light lenses reflect blue and some absorb blue. I like the ones that absorb blue. So if you want to have lenses that are best in front of your eyes for blocking blue, I would use the ones that filter and absorb blue, not the mirrored blue. That was only about 20%. And so I tell them about that. And then I say, the best way to block blue eyes is by taking a pill. And if you want to know more about it and how it works and why the research is, I'll tell you. And some people say, nah, just deal with it. Okay, fine. Just move on. Don't take a lot of time with that. You can only take so many people on this ride with you. Not everyone's going to do it. So treat the ones that are listening to you. Try and get them to listen to you, but not all of them are going to do it. Again, patient questions, the vision's off. Contrast sensitivity is something that we don't really measure very much in the clinic settings, but it's a significant thing that causes people to have problems. And that ability to see better is like lighting up the menu when you're at a restaurant with low light conditions. So you improve the contrast by taking a carotenoid. You improve night vision. You improve glare recovery time. All these things are going to be improved with the correct amount of carotenoids in a lipid formation. So if they are asking me how they see better at night, I'm going to tell them to take carotenoids. And I'm going to tell them to take them pretty much all the time. The photoreceptors are very important, the rods in particular for night vision, and they do degrade over time. We've seen it study after study over macular degeneration patients, and the carotenoids can show a recovery process. In the years that I worked in Wisconsin, I found that some people with consistent carotenoid ingestion over a period of 3 to 5 years actually lost drusen. And if you use this and people are consistent in taking it and you know and verify that they are, you will see this too. I've talked to retina specialists, other practitioners around the country. I thought it would, at first, would just reduce the number of increased formations of drusen. Well, it's not just that. It actually does reduce drusen formation, and it reduces drusen in the back of the eye by taking carotenoids. And again, why is this? Well, Eyelids showed that in 97% of the patients had peripheral drusen. So if you think about AMD as a retina-wide disease and carotenoids getting into the system, going through the gut into the liver, riding on the HDL molecule as it does, and goes into the eye, it piles up in the macula. It can be measured. We don't have a device in the United States that can measure, but Heidelberg has an instrument in Europe that can measure in a spatial way the amount of macular pigment optical density. And you can see it piling up in the back of the eye with ingestion. So we know it gets in there. Lately, they've been studying drusen and Alzheimer's, as well as a reduction of dementia with carotenoid ingestion. We talked a little bit about drusen formation as kind of like an oil slick with puddles, which you can see, and those are the drusen. And these are MAC complexes. It's 75% genetic, and it's got a crossover with Alzheimer's. Of course, it's about this far away from where Alzheimer's happens, from the back of the eye, and it makes a lot of sense that these MAC complexes are very similarly deposited because of retina tissue degradation over time. And then again, research shows carotenoids reducing AD progression, Alzheimer's, in a placebo-controlled study in Ireland, significant study. Pseudophakic patients can benefit from carotenoids because, of course, you take that crystalline lens out, and then all the blue comes in. I mean, even if you use an IOL that has blue blocking, it's about 20% reduction. So everyone who has cataract surgery, kind of like that vitrectomy, it opens up the eye to lots of damage. There's no studies, of course, because no cataract surgeon wants to show that cataract surgery leads to AMD. So patient signs, findings, macular degeneration, people that have a significant other that has macular degeneration, it impacts them because they're the ones that take them in for the shots. And they know they don't want to have that. So people are interested in, particularly in those settings, they want to be preventing that problem. Most of the patients are being prescribed Eyelids vitamins. Now, I take people off of Eyelids supplements because it's got too much zinc. Too much zinc in an oxide form. I was working with Pure Encapsulations, a company that made vitamins for people, and they said they would not make zinc in an oxide form for a pill. They said it's bad for humans, just bad. They wouldn't make it. They'll make it in a citrate or picolinate form, but they won't make it in an oxide form. And the Eyelids, of course, has 80 milligrams of zinc in an oxide form. And about 15% of those are genetically predispositioned for zinc toxicity and AMD loss. That's been shown in a study that Kaufman did in Ohio just about 5 years ago. So if you can take genetics, you can see whether or not people could or should have zinc, not in an oxide form, but they could have it in a citrate or glucosinate form, but about 15% of them are going to be not taking zinc because it's bad for them. Takes about 3 months and it increases through 5 years with carotenoid supplementation. It's something that people are born, the macula lutea is the name we gave the fovea back in the day. And what that means is yellow macula. And and have seen that about 25 years of age, people lose that yellow spot. And that yellow spot also goes away more in women who breastfeed because the carotenoids are given to the baby through the breast milk. And it's been shown that the need for carotenoids in infant formula when they're supplementing instead of breastfeeding is important, and several infant formulas have carotenoids in them for brain development in kids. But it helps everybody. And there's about 600 in nature. There's some things that I say to people. It seems like I've been able to kind of develop a rhythm if they're interested in listening about what they should do for prevention. There's 600 carotenoids in nature. That's what makes nature beautiful and pretty and red and green. And there's about 12 that get in the blood supply, and there's exactly 3 that get in the eye and brain. That's mesozeaxanthin, zeaxanthin, and lutein.
Hey, David, you're right at 9:23.
Okay.
We needed to land this about. So if you have like a final, like kind of, 30-second minute comment so that we can land this, because I have to do some housekeeping slides.
Great. Well, I'm sorry I'm not able to get to these, but you can read them and study them and see what works for you in your practice when you want to tell people about supplement ingestion and how to prescribe. I use a pad and pamphlet. I emphasize the products over the counter. You need to have a independently certified product to get the dose response that we think we need. You can get them here. You can get them in Amazon. We just want to make sure you get them and take them because it makes a difference. The vitreous supplement is outlined there, and you've got it in your handouts. This is the 2/3 reduction in the floaters that people got in the study, about 2/3 reduced. And I think you're going to find that people are very interested in this. Not everybody, but the number that you will find are very interested in this are significant. Sorry, I have to slip through that, but there's the question at the end, and then I'll do a conclusion slide.
We just to save time, we'll just, the most reliable absorbed form of fish oil are found are, and you can give the answer.
Oh, yeah, triglyceride formations.
Triglyceride. Yep. Okay. Go ahead and do your conclusion, and then go ahead and stop sharing, and then I'll pull up the final slide.
Anyway, so I think health and wellness can be a really important part of your practice. I think people are very interested in that kind of thing for the most part. Not everyone. I think it's a very rewarding area to be in, although I still treat people all the time. Visual performances matters, and degenerative conditions are not going to go away, but through supplementation, we might make it a little bit less. So I appreciate you all spending time with us, and I'll let you all go. Thank you.
Yeah. So go ahead and unshare so I can we can put up the final slide here real quick. Thank you.
Thanks a lot, David. Really appreciate it, though. I thought I got a lot of tips out of this, and I really enjoyed.
Thank you. Appreciate you.
Let's see if I can pull this up. So everyone here, before we move to the final slide, right here, there's a little red dot by survey. If you click on it, you'll be able to do that survey before having to wait for the next 4 minutes. Joe, are there any final questions?
No, I think he's covered everything.
Perfect. So thank you for checking for that. And so David, thanks for doing comprehensive eye care wellness from eyelids to retina. As Joe said, a fantastic job. It's right that near and dear for what I've been studying over the last few years. This was a synchronous virtual course. David, thank you for doing it.
Appreciate you. Thank you, Joe and Greg. Thanks for the audience. Bye-bye.